and let our attendees in. Here we go. Hello, everyone, and welcome to today's virtual interactive panel discussion brought to you by the ACHE of Northern New England. My name is Tia, and I will be serving as your ACHE technical host for today. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event, and we absolutely encourage you to use it to help keep this session as interactive as possible. Open up that chat box, say hello, introduce yourselves, ask questions. We really want to hear from you. This event is being recorded and will be available for viewing in ACHE's Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE Virtual Interactive Education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 Virtual Interactive Education credit applied within 2 weeks from today's event. We do encourage you to complete the evaluation. I will share the link in the chat box shortly, and then I will reshare it before we close out. Now, to begin, let me turn it over to Kevin.
Well, good afternoon, everyone. Hopefully you can hear me okay and see the screen that I'm sharing. Okay, maybe some nodding heads if you can. All right, Debbie, I see you shaking your head. Appreciate that very much. So thank you all for attending today's discussion. The discussion today is the utilization of the advanced practice provider workforce in the current healthcare environment. I imagine this is a topic that many of you think about on a daily basis. I know that the panelists we have here today think about it every day, if not probably more than they want. But anyways, we're excited to be here. I want to thank Mark Bonica and the board of the ACHE of Northern New England for having us here today to present this important topic. I think I know many of you probably who registered for the call, but if I haven't met you before, my name's Kevin Donovan. I'm currently Managing Director for Healthcare and Physician Provider Enterprise Solutions for Warbird Healthcare Advisors out of Atlanta, although I still live here in the frigid Northeast with many of you. I am the former president of the ACHE of Northern New England and the Vermont Regent for the ACHE. So happy to be able to provide this education for the group today. More importantly, I'm happy and excited that we have two very excellent individuals who are knowledgeable in this area on these topics, Ian, Leslie, and Amanda, to share with us today some of their thoughts. Leslie Turner is the Director of Advanced Practice Providers for Erlanger Health in Chattanooga, Tennessee. Over the last couple of years, I've had the opportunity to work directly with Leslie and can say that she's a wealth of information. So we're looking forward to that. And also joining us today is Amanda McNicholas. Amanda is current trauma program APP and the former chief APP at Tower Health in Reading, Pennsylvania. And I've also had the opportunity to work with Amanda over the last couple of years. So I'm excited about these two great leaders that we have here today. This is our agenda for today, and lead off, and Tia sort of said it, but the expectation of ACHE is that these educational sessions are interactive and they're learning sessions. So, we will be speaking some at you. It's a panel discussion, so we will hear from our experts. But the expectation today is that this is interactive. So we are going to have a couple of quick polls that we hope people participate in and vote on. We'll explain that technology to you when we get there. And then we will have the wonderful breakout rooms near the end that everyone loves to go to, that will have some small group discussion and then bring that discussion back to the larger group. So the agenda, we will basically go over some basic introductions of Leslie and Amanda. We'll let them describe their health systems, their roles, I will briefly go over some real high-level market dynamics related to advanced practice providers that we're seeing in the marketplace today as we work with clients. Amanda, and then with a little bit of help from Leslie, will go over a recently released statement from the American Hospital Association related to APP leadership roles and best practices for that. We've got a number of prepared questions that Amanda and Leslie will answer in panel form. We'll do the previously discussed breakout sessions for open discussion, and then we'll come back to close it all out with some final questions for today. So hoping all of that takes, somewhere between an hour and 15 minutes or so, an hour and a half to bring this session. I think it's scheduled 4 to 5:30, and that you get some valuable information. So with that, I will stop talking at you and let Leslie go first and talk a little bit about herself and her organization and the workforce where she works.
Thanks, Kevin. Thank you all for agreeing to have us here today to present what I think Amanda and I feel like is a very important topic. So just a little bit about me. I'm a nurse practitioner. I have been in practice for about 23 years, 26 years in totality as a nurse, and then NP here at Erlanger. We are about an 800 adult bed level 1 trauma center. We are right at the southern tip, as you can see on the star, southern point there of Tennessee. We border 3 states at North Carolina, Georgia, and Alabama. We have campuses in, obviously, Tennessee, North Georgia, and then also in Western Carolina. We have a level 4 NICU. We have multiple pediatric and adult subspecialties, primary care, and probably see about 1.2 million patients a year outpatient, and then about 170 or more thousand through our ER. And we also have an academic component as a campus for UT Memphis College of Medicine. We have a Chattanooga campus here.
All right, thank you, Leslie. And maybe Amanda, if you want to talk about Tower Health and your role there.
Yeah, absolutely. Thanks. And thanks, Kevin and Leslie. I'm excited for this session as well. So Tower Health is a 4-hospital health system located in Pennsylvania, here about an hour west of Philadelphia, if anyone's familiar with Pennsylvania. We have one large medical center, which is sort of the flagship, which is Reading Hospital. It's about a 700-bed hospital, level 1 trauma center, comprehensive stroke center. We are, fun fact, the busiest emergency department in the state of Pennsylvania. So that's something that we're very proud of and keeps us very busy. We have 2 smaller community hospitals and then an association with St. Christopher's Hospital, which is a pediatric hospital in Philadelphia. I am a nurse practitioner by trade as well. I work in trauma critical care. I've been just behind you, Leslie, 23 years as a nurse, I think, and 21 as a nurse practitioner. I've served various leadership roles here at Tower Health, trauma program director, chief advanced practice provider officer, some service line vice president work. I have some of our medical group data. So our medical group has about 750 physicians, and we have about 400 APPs, about 200 nurse practitioners, 100 PAs, 60 CRNAs, and a handful of midwives. So we include our nurse midwives and our CRNAs in our APP counts. We have 57 specialties, 131 ambulatory practices, and I have fiscal year to date. So we have about 350 million fiscal year to date revenue for the medical group. So very, very busy here as well.
All right, thank you both. And so we also thought it would be sort of interesting today for the folks in Northern New England to hear from a couple of folks south of us. So unique maybe to get someone from Tennessee and Pennsylvania, although I think we'll probably find today that the challenges in Tennessee and Pennsylvania are the same challenges in Maine and Vermont and New Hampshire and the Northeast as well. So thank you both for attending and looking forward to some of the discussion. All right, so we're going to start off with a little bit of what we're calling pulse checks. This is part of the interactive component of today's session. And so the way that you vote on the pulse check is you just pull out your phone, you take a picture of that QR code, and it will bring you to an easy link. You should be able to just vote to answer this question, and then we'll see some live time results. So the question and some pretty simple questions we've got here for you. So the first question is, APPs make up approximately what percentage of the U.S. provider workforce today? Do you think that's 29%, 38%, 44%, or 51%? So take a picture of that QR code. It should take you to results, let you vote, and we'll give it a second to see people's responses. Okay, so it looks like for those folks, about 15 people voted on that. So thank you for engaging on the survey there. So 15 people responded, and 60% of the people who responded thought that APPs make up 44% of the workforce. And then it looks like about 20% of you who voted think it's 38% of the workforce. A couple of people maybe thought that it was 52%, and maybe one person thought it was the lower amount of, I think it was 29%. So, you know, those numbers are pretty close, but I think that what we know the answer is, the actual answer is 38%. And so a good amount of people got that right, or were directionally correct, I guess I would say. So we do know that according to the latest Census Bureau report, which was 2023, so a little bit dated, but that there were 835,000, give or take, physician jobs, and that there were 503,000 APP jobs. So when you look at the total, it's about 38% of total providers in at the end of 2023 were APPs of some sort. Just sort of an interesting stat. That means for every physician that was practicing, there's about 0.6 APPs per physician that are currently, that at that point in time, were working in the workforce. All right. So then if we know that is how much of the workforce was in place as of a couple of years ago, the question now is, what do you think the projected growth rate for APPs is over the next 10 years? And this is an aggregate growth rate over 10 years. So do you think that's 9%? Do you think it's 23%? Do you think it's 36% or 52%? And again, take out your phone, take a picture of the QR code, and then we will see real time what people are thinking about from an answer. So what's the projected growth rate over the next 10 years for APPs? All right, we've got some responses coming in. All right, looks like with 16 people responding this time, half of you thought that the projected growth rate for APPs over the next 10 years was 36%. And about a quarter of you thought it was 52%. A little bit less at 19% thought it was 23%, and just a person or two thought it was less than that. And so the actual answer is that the growth rate is projected to be 36% over the next 10 years. So as I said before, according to the census report, the Bureau of Labor Statistics, actually, there were 835,000, give or take, physician jobs and 503, give or take, APP jobs, again, averaging about 0.6 APPs per physician. And the projections state that by 2033, so 10 years from the last numbers that were put out, there will be about 869,000 physician jobs, and the APP jobs would rise from 503,000 to about 688,000. So significant projected growth in terms of APPs over the next 10 years. That's a 36% increase. And interestingly enough, it shifts that ratio. So before I said the ratio was about 0.6 APPs per physician. So this shifts to about 0.8 APPs per physician over the next 10 years. If you want to extrapolate that out, and I don't have any data on this, but I'm sure that many of us might think this, it probably won't be too long beyond that if we might see that growth rate continue, with it could be in the foreseeable future a one-to-one relationship based on the growth rates we've seen in the past. We do know, to corroborate that information, that the Association of American Medical Colleges released a survey at the 2024 survey, projecting the number of physicians that are needed and jobs, and looking at the delta between the two. And according to the AAMC survey, they project that the U.S. will face a physician shortage of about 86,000 physician jobs by the end of 2036. So it probably only stands to reason that if we're going to be missing 86,000, give or take, physicians in this country, that we're going to need to have some APPs who are ready, willing, and able to step up to meet the ever-growing demand for healthcare in this country. So probably doesn't make sense, probably hopefully aligns with what people are seeing in their own market and their own organizations today. All right, a couple of key kind of high-level discussion points that I'll talk to you about the APP workforce in general. Probably each one of these topics could sort of be a seminar, webinar on its own, but we just want to real high level set the bar in case, recognizing there's different understanding on this call of familiarity with APPs. So level set a little bit on APP workforce today. Training requirements and what we're starting to see as trends in that area. We've talked already a lot about shortages, but give a little bit more information on that. And at a very kind of high level perspective, talk about compensation. I think compensation is something that, again, could be a full day webinar or a discussion in terms of the trends and the ever changing dynamics on that area. So I'll go over this and then we'll jump to our panel. So from a workforce perspective, we've already discussed the workforce demand moving from 0.6 APPs to 0.8 over the next 10 years. Hopefully, many of you did the required reading that was part of the assignment today prior to today's session. If you did that, you would have seen that there was an MGMA stat poll that was also somewhat dated. It was a 2023 poll, but it was included in the reading. And at that point in time, the MGMA asked their medical groups, how many of you are expecting to add new APP roles to your medical groups in the coming year? And about 2 out of 3, or 65% of medical groups said in 2023, they're planning to add new APP roles. From what we've seen, and I know Leslie and Amanda will talk about this later, but, we've seen that trend continue over the last few years. And I'm sure if MGMA did that poll again today, it would probably be at least that 2 out of 3. And again, that's important to note. Those are new APP roles. Those are not replacement APPs for people who've resigned or retired or et cetera. So again, a lot of growth in the workforce, a lot of demand. So if you are an APP, or if you're thinking about becoming an APP, probably a good investment, I would say. And maybe Leslie and Amanda can talk about this later today as well. But, I think a strong job market if you're looking for what maybe a future career opportunity would be. In terms of that career training, we know that NPs and PAs are trained pretty differently. CRNAs and midwives are also trained a little bit differently as well, but we know that NPs are educated through nursing-based graduate programs, while PAs are educated more through what you might call a medical model curriculum. And while both models produce competent clinicians, the training does differ. And, sometimes they do go into different specialty areas as well. And maybe Amanda and Leslie can share some of that with us today, too. What we do know, and we're seeing more of, is that readiness to actually practice out of training varies greatly. And it really a lot of times depends upon the experience the individual has had prior to becoming an APP. And what we also know is that where maybe historically you would see some very strong nurses who had lots of years in the ER or in some kind of an environment like that become an APP, we're seeing more and more people go almost directly into these programs, after nursing school or through some kind of other, maybe going to a PA program after having an undergraduate degree, those types of things. And so we're seeing people coming out with varying readiness at graduation. And what this means is that lots of health systems are putting a lot of resources into onboarding or additional mentoring for those folks as they come into the workforce. And health systems are now starting to invest in things like APP fellowships, APP residencies, long orientation programs. Gone are the days where you sort of hire an APP and just throw them to the wolves. So at least hopefully many of those days are gone. And I know that, again, our panelists today are going to talk a lot more about that and what they're doing in their organizations as it relates to that topic. From a shortage perspective, we've talked about that a fair amount. But again, considering the physician shortages, there will be an ever-increasing demand for APPs. What we also know, unfortunately, is that where physician shortages are the most acute, often in rural communities like those in northern New England or in underserved populations, those, unfortunately, are where the APP shortages are generally the greatest as well. So in some of the more urban areas, there's generally more of a workforce. And so this is where things like recruitment and retention in rural communities, underserved communities, becomes increasingly important because APPs often fill, an incredibly important role as often the primary, caregiver and medical provider in those communities. Similar to rural, we know that access to behavioral health and primary care physicians are also an area that's really challenged right now. So it's hard to find behavioral health. It's hard to find primary care physicians, and very similar, unfortunately, finding a primary care APP or a behavioral health APP can be challenging as well. But definitely an area that APPs can step up and fill some of that demand, hopefully in a number of our communities. So, we're going to focus, and they have focused a lot on NPs and PAs today. But Amanda discussed CRNAs before, and I'm sure many of you are familiar with the challenges of getting CRNAs in your local communities. We know that CRNAs are generally very heavily relied upon in rural communities, and many of the communities in northern New England, or the states, I should say, have rules, allowing CRNAs to work independently. And so we know that there's a tremendous need for CRNAs and also a tremendous shortage. According to the American Association of Nurse Anesthetists, there are about 2,500 to 3,000 CRNAs coming out of training every year. And there's currently about 67,000 CRNAs in the United States. The challenge is that when there was a recent survey done of existing CRNAs, about 12% of those 67,000 CRNAs said they're going to retire in the next 2 to 3 years. So if those 12% retire, and we're only turning out 2,400 to 3,000 new CRNAs per year, it probably means we're going to have less CRNAs working in 3 years than we do today. So if you think the demand is high today, it's probably not going to get much better over the coming years. We know there's a lot of resources being invested in more CRNA training, but those investments in those training programs, those will take a pretty long time till we see some meaningful numbers come out of there. So maybe the unfortunate message for you all today is the market is tight, and that market's probably going to continue to be tight. And again, why you should be thinking about recruitment and retention of your valuable APP workforce. Which really leads to the last topic as it relates to compensation. And because of all this demand, we have seen APP salaries across the board, skyrocket may be a strong term, but grow pretty significantly over the last number of years. And again, this could be a large topic unto itself, but compensation varies widely by setting and by region and by call burden and by your clinical training. I think we're starting to see some of the compensation changes or variances between NPs and PAs tighten up. This is always an interesting topic, and I know Leslie and I have dealt with this in terms of if you have an NP or a PA working in primary care, do you compensate them exactly the same? Is there a difference? Actually, I think, Amanda, you and I worked on that topic in the past as well. So, we're seeing that the compensation between NPs and PAs is starting to narrow and become a little bit more consistent. But we still continue to see compensation changes by specialty, area of the country, etc. I've mentioned recruitment retention. We have started to see lately that employers are increasingly differentiating themselves through sort of sign-on bonuses, professional development funding, leadership pathways, and I know our panelists will talk about this today too. But as it relates to sign-on bonuses, there was an MGMA stat poll, and they do these polls weekly. So if you are ever interested, there's all kinds of cool information that comes out. You can sign up for it. But in another poll, I think it was in the last week or so, the MGMA identified through their poll that 80% of medical groups now have assigned what I would call clawback provisions on sign-on bonuses. So the majority of practices are giving APPs significant sign-on bonuses, and they're saying if you don't stay 2 years, 3 years, you have to pay that back as a tool to keep people engaged and local. There was another study that was recently done by AMN, and AMN does a lot of recruitment, those types of things, and they say the average sign-on for APPs these days is about 12,000. And our experience is that number varies probably a fair amount by specialty as well, maybe a little bit less for primary care, maybe a little bit more for CRNAs. CRNA sign-on bonuses, we've seen some organizations go as high as $50,000 these days. So, it varies. But basically, long story short, we know that compensation for APPs is growing. It's been about 8.6% over the last couple of years, year-over-year growth. And again, in some places like CRNAs, it's in the high double digits. So recruitment, retention, making sure you're staying on top of your compensation plans is an incredibly important thing for you to do as leaders within your organization. Okay, so now to get to the meat of today's discussion, we're going to jump into some of the panel discussion with Andrea and Leslie. I am going to introduce some broad categories of questions, and then within those broad categories or areas of discussion, there's some specific questions that we'll have Amanda and Leslie look to answer. And so the first 3 areas are listed here: optimal utilization, recruitment, retention, and leadership decision-making. So I think what we'll do is we'll start with optimal utilization of APPs. Well, I'll start with Leslie first, and then we'll go Leslie, Amanda, alternating. So, Leslie, why don't you talk to us a little bit in terms of use of APPs, what you're seeing in your market or what you know from your peers as it relates to scope of practice, getting people to work at the top of their license. I know we've talked when we were just planning for this about some challenges for credentialing with payers. And there have been some barriers, and we've seen this in some of the organizations we work in, barriers to APP use and maybe some of the solutions to those barriers. So with that, talk to us about optimal utilization.
Sure. Thanks, Kevin. So I'll give a little bit of background too, just on our kind of makeup of APPs here. So we, pretty similar to what Amanda reported, we have about 550 employed physicians on our medical group. And in that we have a little under 300 APPs. We kind of span the same specialty range. We have heavier NP focus, about 70 to 100 PAs. And then we have about a handful of midwives. We do not employ our CRNAs, so they are employed by an outside group. And so that kind of makes up our our population. I will say the rate of hire is very high for APPs. They are constantly hiring new APPs in departments, spreading departments. The goal is, again, access, and typically you can get access points a lot quicker with APPs. Unfortunately, the credentialing process is about the same for APP and physician, so it's still about a 3-month kind of lag time once you extend an offer. We keep hoping that with the utilization of technology and credentialing software, we can speed that up, but still it's about a 3-month lag time. Some of that has to do with getting you enrolled with payers. And that can be challenging when payers don't want to recognize the APP as an actual provider and require you to still utilize the physician. We have really only about 2 payers in our area where that's an issue still. Most do recognize APPs as providers. We have about 17 of us. I work in primary care. I, like Amanda, have worked in many different areas within our health system. I was acute care trained initially and then went back for a postmaster's FNP. So I've been working predominantly in the outpatient sector for the last 13 years in internal medicine, but I have worked inpatient with our burn unit service when we had that, also in craniofacial, and then did a brief stint in cardiology inpatient as well. So kind of worn different hats. And I think that's a benefit to APPs too, is that there's a lot of ability to transition to different areas of practice. So it's good and bad, but it makes you very portable. So you can switch and fill in gaps where need be, should the demand arise and you're ready for a change. So that is a benefit. Unlike our physician peers who go to school to specialize in GI, they're pretty stuck in GI. They can't decide to do cardiology in a couple of years unless they go back and spend a lot more time and money. I do think, to your point around the pay aspect too, Kevin, like when I think back of what my salary was when I started this journey in 23 years ago versus what I'm paid now, the landscape has changed greatly. And the demand is high, and there's not enough providers to see all the people in the population. So I think that demand is going to continue to grow, as you mentioned in those statistics. I do think a challenge we face is really helping our service lines to utilize their APPs at the top of the license, and that is where some of the payer compensation struggles can come from. If you're in a shared RVU type environment, which I know some health systems are, where you kind of pool those RVUs and then you split that money up between the different providers within that service line, and you kind of get this equitable, like everybody's, working at the top of their license and trying to meet the needs as efficiently and effectively as they can, versus everybody's earning their own RVUs. And in that situation, you're going to kind of run into a challenge where you may be pitting the APP against the physician for capturing those RVUs. We do see this more often in our medical subspecialties versus our surgical. The surgical subspecialties obviously have a much higher rate of return from a productivity standpoint due to the procedures and surgeries and operations that they can do versus our medical subspecialties, which are really dependent upon those RVUs. So we do see a challenge in that. And in Tennessee, Georgia, and in North Carolina, because we have APPs in all 3 of those states, that we are still a collaborative supervising practice state. So we are not independent, so cannot practice independently. You do have to have oversight.
All right. Thanks, Leslie.
Thanks.
Amanda, you want to weigh in on that one?
Yes, I mean, Leslie, you covered so much, so I'm gonna have to. I was like, she is skipping ahead here too. So yeah, I'll just comment on, very, very similar. We're not a full practice authority state. I think, most of the full practice authority states, and it's about a third, I believe, on last check of the states do have full practice authority for nurse practitioners specifically. And we're seeing that in the Midwest, where there are all the physician shortages. That's where, it becomes more imperative to have NPs be able to work without a collaborative agreement. In Pennsylvania, we're a reduced practice state, which means we have to have 2 physicians on file with the state in a collaborative agreement. There are other states, I'm not sure which ones they are off the top of my head. So sort of the lowest level of scope of practice for APPs or for nurse practitioners is restricted, and that's where they have to have supervision similar to a PA, or delegation of tasks for any of the work that they're doing. So hopefully Pennsylvania will get to full practice. I think, we are very saturated with both APP schools and hospitals and physicians in this area. So I think there's not as much of a need necessarily in Pennsylvania to have full practice. So, there are certainly, there's a Senate bill that's been there for many, many years that's just kind of stuck. So we'll see what happens with that. Some of the other barriers that I've seen personally are self-imposed. So, a few health systems, and we had that here at Reading or at Tower, I should say, was we had, antiquated guidelines or medical staff bylaws that were potentially or not potentially intended to restrict APP scope of practice, maybe because physicians at the time weren't comfortable with the scope, or they weren't familiar with the role, or like Leslie mentioned, it was intentional because they didn't want RVUs to be shared with APPs. Either way, I think that's one of the lowest lying fruits sometimes. It's just, sometimes people don't know what they don't know, and they think, oh, well, it's in this policy. That means that nurse practitioners must require co-signature or must require that I see every patient. And that's kind of one of the easiest ones to fix, is to clean those up. And we'll get into a little bit more about the importance of APPs when it comes to bylaws and bylaws creation when we discuss some of the paper that Kevin mentioned. Some of the other culture is really, I think, the biggest, scope of practice that's kind of tied to these guidelines and self-imposed restrictions. But I think we've all, dealt with, some service lines have been more progressive with allowing their APPs to be independent. I think that really, needs to come from the top down. We really need, strong executive leadership who supports the APP leaders, and in ensuring that APPs are seeing patients when appropriate, independently. And I always talk a lot about the it's virtually impossible. It's so hard to generate revenue in healthcare today regardless, but if you're paying an APP salary and a physician salary to do the same work, you're just making it even harder. So sometimes when we spin it that way, it makes a lot more sense. And then we'll talk also, I think, in some of the other slides about incentive models and how you sort of get past that. I don't want to share my RVUs with an APP because that's a challenge as well. We have the same here. We have some payers who do not recognize APPs as the billing provider. We're seeing that number go down, like Leslie mentioned, which is exciting. Similar things to payer credentialing. I think that's kind of it for my scope of practice.
All right. Great. Well, thank you all. So let's jump now to recruitment retention. So I sort of beat that horse before when I was making my comments about market dynamics. So when you think about, in your experience, where you work today and what you've heard and seen from your peers and across the country, maybe if you could speak to us about what you're seeing in recruitment, retention, the environment, maybe some best practices, maybe some worst practices if you've got some of those. But I know we also discussed a little bit before about fellowships and transition to practice models. We've talked about incentives. So Amanda, we'll let you go first on this one so you can cover all the good stuff, and then let Leslie see what she's done.
No, maybe I'll just start. Let's both of us talk about fellowships to start with. So we have fairly limited experience here with fellowships at Tower Health. I have many colleagues who have many different specialty line fellowships here in the Pennsylvania/Philadelphia area. But we started our first fellowship, and it was in neurocritical care because we were starting a neurocritical care service line. We didn't have any neurocritical care trained APPs. We had 2 seniors, and we needed to grow a team of 6 or 8 APPs. So we started a neurocritical care fellowship, and it was incredibly successful. Very, very high satisfaction rates. They stayed with us for a long time. Satisfaction rates from both the physicians on that team and all of the APPs. In an ideal world, I have specific specialties in my area, such as neonatology and cardiac surgery, where I would love to create fellowships to just have a pipeline of, these are really hard positions for us to fill. I don't know if folks on the line or Leslie are seeing the same thing, but pediatric intensive care, neonatology, cardiac surgery are sort of what we're seeing. I know the literature speaks about emergency medicine being another one of the sort of more popular, emergency medicine and critical care in general being some of the more popular fellowship areas right now. I know also one of our colleagues did something very similar to us down at the University of Pennsylvania when they needed to hire a very large critical care APP team. They created an APP fellowship that has continued and is very successful. We have a trauma fellowship in our area at a neighboring hospital. So I think we're going to see more of them. And, Kevin mentioned the differences between, I feel like it used to be very different where PAs came out and they kind of didn't have a lot of clinical experience, and nurse practitioners, especially if they had years at the bedside, were easier to transition seamlessly into some of these roles. But it's not that way anymore. Like Kevin said, there's a lot of programs that are just sort of APP mills and are pushing folks out from online programs and not requiring. There's not as much oversight, I think, of the clinical education at times. So they feel very green when they're showing up for APP roles as well. So I think we're going to see more of that. And I think with these shortages, it's just going to perpetuate the sort of pushing of, getting APPs through programs and out into our, facilities. And then we're going to have to work on making sure that they, can continue to provide quality care.
Yeah, I'll echo what Amanda was saying too, just in regards to the need for fellowships. I think we're beginning to embark on that process here. We're in the very infancy stage of development, but have begun meeting with our strategic planning team and administration, business development to look at where is our growth trajectory best able to support a fellowship so that we can maintain that growth trajectory. I will say, when I explain NP versus PA, and again, like what Amanda said, like back kind of when we first went, you couldn't even be considered for a program, advanced practice program, unless you had some years at the bedside as a nurse. And so when you got into your program, you kind of had some experience under your belt so that you could really apply that to what you were learning in that advanced practice model. Whereas our physician assistants peers really spent most of their time gaining clinical hours in the OR, holding, instruments or what have you. And so, they came out automatically with a real heavy surgical focus, procedural focus, because it was so dependent upon, their clinical time was usually dependent upon that. So now, of course, with the demand and the shortage, they are churning out, both NPs and PAs with great frequency, and we're seeing programs like she mentioned pop up everywhere. The difference I feel like with physician's assistants is that when they go into their program, they come out as a generalist. So like they get a little bit of everything when they're in their program. So they get, OB, they get internal med, they get surgery, ER, they may choose some specialties that they get as well. Whereas we as NPs get our generalist approach in our RN program. So we learn how to take care of the disease and how it affects the patient as an RN. Then you go back and you specialize in your advanced degree, but you pick that area you want to practice in. So it may be acute care, maybe it's family, maybe it's women's health. So we kind of fracture the advanced practice part as a NP. You can come out as a generalist as an FNP where you're working in primary care predominantly and you kind of can treat birth to the grave, but you're not coming out with the ability to necessarily manage the high-level tertiary care patient and then also the outpatient primary care patient unless you've done a dual program. So that's one of the big differences I feel like with NPs and PAs, and that's still kind of the case, except in the sense that our nurses are not getting bedside experience before they go back to their NP program of choice. We are participating in a program out of Nashville. It's called Thrive AP. It's a transition to practice program. And I do think you have to do something. I think you've got to come alongside these very new, very green hires and give them some additional support as they're coming into their role, because they are coming out with very little experience, and yet we're expecting them to manage pretty complex, pretty sick people right out of the gate. I do think that in some of our service lines, we have very robust orientation processes. Like in our home critical care, they spend several months on orientation. But one of the things our council did was asked for all the APP leads to write precepting guidelines for their service line, because you would have people come into a role and not know how long they were going to precept. Who am I going to be with? What does that look like? And so I do think some standardization around that is helpful for those new people so that they kind of know how long they really are going to get trained into that role, depending upon, how much experience they have as they come in.
Yeah, and then sort of touching on retention, I think that's I've read that one of the main reasons that a new to practice APP leaves a role is inadequate onboarding. That's
Exactly.
cited across the board, right? Just
Exactly.
and lack of clarity around the role. So I think that's so important,
It's
and that's
so
work. Yeah, that's work that we've done here with standardized onboarding as well. And then I think for retention, I think there's two different. What I see is retention in the first couple of years, and that tends to be people who either weren't onboarded correctly or are chasing, a higher salary a couple minutes down the road, versus the more senior APPs who, if they love the environment and they feel valued, I think feeling valued is something I hear a lot, from what more senior APPs want to feel to stay with an institution. If they're feeling valued, then they won't leave to go make $10,000 more or to seek out some sign-on bonuses. So I think I hear that a lot. That we need to make sure that we're valuing our APPs and that they feel that way and that they have a voice at the table. That's some of the stuff we'll get into later. Just making sure that they have a clear lane in the healthcare ecosystem, and people know what their role is. And so that's where we're seeing that's retention for us. Recruitment, we don't really have too many recruitment issues. I would say recruitment is going well in general, aside from sort of those hot specialties that I mentioned, neonatology and CT surgery, and that's kind of across the market in this region. Is that's pretty common. So I think overall recruitment, and we've gone back and forth with sign-on bonuses. Kind of the market, I think, is, there was a time we were giving them to everyone, then we were, giving them to no one. Then it was, only very special specialties would be sign-on bonus eligible. So that has changed. But I think that, we've been able to continue to recruit really solid candidates who do stay with us if they're properly onboarded, they feel respected, and they have a voice at the table.
All right, good information and a good segue, Amanda. So you said voice at the table you ended with. So the next question, global question we want to talk about is leadership and decision making, and specifically as it relates to APPs and how APPs are involved currently, or maybe what has worked for you or what isn't working, maybe some of the leadership roles they have. Inclusion on the medical staff, where they fit in that medical staff is always a touchy subject. I know I've had that conversation a lot in the last couple of years. So we'll go, Leslie, let you go first on this one. So talk to us a little bit about leadership.
Yeah, so I think, leadership is very important. And I think having structure around your APPs from a governance standpoint, I think is also really important. It, again, helps to feed that kind of culture of, that your role is important, it's valued, that your voice is important and it's valued. And so we've worked really hard to develop that governance structure here. We, like many, do not have a voice at the table from a medical executive committee standpoint. We do have a professionalism committee that reports directly to MEC. So we do have kind of an avenue there, and I work directly with our quality team as well. So there's definitely avenues and branches, if you will, off of our MEC where we're getting more involvement, have a great rapport and relationship with our CMOs. So there's a good kind of pathway of communication and collaboration that does happen there. But from a formal, hey, you have a seat at that table and a voice at that table, we still have not been able to break that barrier. In our Erlanger Medical Group, I do sit on that committee as the APP representative and have for the last several years. So that's been a helpful, at least from an employed standpoint, to have a voice at that table. I also co-chair one of the Erlanger Medical Group committees and then sit on two others. And then we also have APP-led committees that are specific just to the APP role. And that's been very helpful in us really helping to promote us globally across the health system in regards to onboarding. Like Amanda mentioned, there's so many gaps in onboarding, and it's such a high reason why people leave, because they come on and don't have any idea what's the expectation, what am I going to be doing, who am I reporting to. So I do think that having these committees to identify some of these weak areas so that you can develop programming and process to help combat that. One of the things our onboarding committee did, in addition to having the service lines develop precept and guidelines, was we developed a mentorship program. Kind of a big brother, big sister, kind of little brother, little sister, where you pair up with somebody who is really senior in the organization, has been around for a long time. And so it just gives you that kind of hand holding to walk through your onboarding period, where you have that person you can call and say, hey, I don't know where to go to get a lab coat. I don't know where the lounge is to go eat lunch. Like, I just think those things are really important as you develop that culture. And I think promote leadership. Like, you really want to encourage people to get involved. And so when they feel connected and they feel like they're really welcomed, then they're going to have more passion around being involved and sitting at the table at these committee meetings and having a voice and having a presence, and their input is very valuable because they do make up a large portion of the provider work staff.
Thanks. I think is the next slide the AHA.
Yeah.
Maybe we'll just go into that to avoid redundancy, because I think that really summarizes a lot of what Leslie said and a lot of what we've been talking about. But like Kevin mentioned earlier, this is a recently hot off the press a framework that was a joint venture between some APP leaders. Some of them were actually my colleagues, and they loved, working on this piece with the AHA. And what they wanted to do is create a framework that would be scalable for, all different size organizations, basically to guide APP leadership. And some of it's really simple, but in general, it starts with just sort of identifying what an APP role is, making sure everyone at your institution understands the role, understands the scope of practice of the role. And then after that, creating, an APP leadership council, like Leslie mentioned, an APP, leadership across different service lines, ensuring that APPs are onboarded correctly. It's really everything that we've just been talking about, ensuring that when there's an APP intervention that needs to be performed, that there's an APP peer at the table, that it's not, physician driven without an APP advocate. It also speaks to the importance of APP leaders having access to data, which I really think is important. And I've spoken to other APP leaders who were kind of put, in APP roles, sometimes at a hospital or system level, and really just not given any tools to be effective. And sometimes they don't know what to ask for, but they're just not being shared financial reports or productivity, or, involved in any of the budgeting or strategic planning. So they really bullet out how important that is as well. They also talk about, you just mentioned the bylaws, that APPs must be involved in the creation of medical staff bylaws, and to leverage those bylaws to ensure that scope of practice is at top of licensure. Ensure that APP leaders are at the table for compensation. Those, there should always be a voice at the table for compensation, peer review, and credentialing. So it really just pulled together nicely, and it's a nice read. I don't know, Kai, don't know what Kevin sent out as your pre-reading, but if you're interested, this is a really quick read. I think it's 2 pages, and it really is a nice scalable framework that folks can use to kind of, make sure that they're meeting all the marks when they're looking to create an APP leadership structure.
Yeah, great point there, Amanda. I don't think we included this one in the pre-read, but we can make sure, Mark, maybe afterwards we can get this out to people. It's easily found if you just Google it.
Yeah, true.
We can get the link out to folks. All right. So now we're going to jump into a couple more questions before we get to breakout rooms, and hopefully we can get the breakout rooms because we've had a lot of robust discussion. But the next conversation is about APP production and quality. And so, how do you measure productivity for APPs? Is that something you measure? Do you measure quality? Do you include that in contractual design? What are the trends you're seeing out there in the marketplace and in your own organizations? And I think, Amanda, it's your turn to go first on that's what.
Yeah, sure. I can start with this. I can sort of speak to the different incentive/productivity models that I've lived through and that I'm familiar with from other health systems. So we previously had our physicians and our APPs on a very similar incentive model that really wasn't productivity driven. There may have been some sort of high level volume goals in there, but it was mostly quality patient satisfaction, sort of, academic, work that the providers are working on, that they could get some credit for. And then maybe, goodness, it's been a few years now, we moved both our physicians and our APPs onto an 80% productivity model and 20% quality. That was not an easy transition. There were certainly some blood, sweat, and tears and kicking and along the way. And I will say that a lot of folks thought that that wasn't going to work, that we were going to be, placing APPs and physicians, forcefully putting them in competition for RVUs, and this wasn't going to be feasible, and there wasn't going to be enough to go around, et cetera, et cetera. And I'm happy to say that that's not been the case. Both arms, physicians and APPs, continue to become more productive. I think this actually, in a very good way, forced some of those more reluctant physicians to look at how they were utilizing their APPs. And it's been really successful. I know there's some other places who use just sort of a raw volume count for productivity membership, or productivity measurement, like the number of visits or the number of patients seen. I really struggle with that because we all know that visits, range in acuity. So you can't it's like apples to oranges if you're just looking at a raw number in many cases, and you certainly can't compare that at a different specialty. Maybe you could do that within, primary care, but not in the different specialties. I am familiar with another incentive metric that a health system uses for APPs is patient satisfaction. That's actually like their primary metric, which is interesting. I do know another neighboring health system who doesn't have all of their APPs billing. So this has been a challenge for them. Sort of they're newer to practice. APPs don't bill until they're a few years in. And then they start billing. So they're still sort of struggling with how to create some sort of productivity incentive metric for them. Interestingly, I'll just add that this health system actually pays their APPs more once they become billing providers, which is something I have never heard of before. And I think that's kind of interesting. But that was something that I just heard recently. Chart turnaround time is another metric that I've seen for productivity and sort of incentivizing closure of charts to get those bills out. And then quality, we have all sorts of quality measurements. We've really moved away from here specifically, specialties, in physicians included, really likes to use their own quality. Like, I want to come up with my own personal, thing that I feel like I can directly impact because I have control over it. And sometimes, these are all important goals, but if they're not really, affecting the bottom line in any way, or really, something, then we had to kind of say, can you come up with something different? So now we're using more organizational level goals, and have sort of everyone working toward the same goal. So that's been successful as well.
Yeah, I'll kind of just briefly echo on that. We've just begun with Kevin and his team coming on board to incorporate some quality metrics into incentive pay. And it was, as Kevin can probably report, it was an uphill climb, and we're still climbing, but we are embarking on that and starting to see some outcome from that. And we chose to go similarly to what you mentioned, Amanda, like more kind of metric based, key performance indicators, like what are, whether it's completing Medicare wellness visits, whether it is keeping hypertension or hitting those preventative health screenings. So we're looking at those kind of measurable, but like things that really are meant to improve quality in the patient and like their actual overall quality health, and not just simply churning and burning with numbers, which obviously access is a big issue. And we all know that. We talked about that a lot on this call, that, we have a lot of people that need to be seen, a lot of providers that are working at the very max of what they can. And we're seeing a lot of provider burnout as a result of that. So I feel like we're at this kind of pivotal moment, I feel like, in healthcare, where we're going to have to see a shift away from just the productivity around numbers, because we're burning out our healthcare providers, and they're leaving the healthcare profession, or they're choosing not to go into it at all, because it's just too much. It's too much to expect somebody to see 40, 60 people a day, maybe in an orthopedic subspecialty, and then spend all day in the OR the next day, and then get all your encounters closed, and all the things that we're seeing come out. So I do think quality, and especially patient satisfaction, should be a big component of that, because you do want your patients to feel like they're getting that time and they're getting the quality and the attention that they need, and then they're not just a number on your census list for that day. So I think we're at a kind of a precipice where we're going to probably see a real demand for this to need to shift, just so that we're not burning out our provider, population.
All right, thank you guys. And so, maybe to build on that, Leslie, so talking about all the pressures on, providers, physicians, and APPs, another major pressure point these days is call, right?
Correct.
And that's especially acute in some of these smaller markets, and many of the hospitals in New Hampshire, Vermont, and Maine are critical access hospital, and the benefit of having you both here today is you both work in systems that have big hospitals, 600 beds or more, but you also have critical access hospitals and smaller hospitals. And so be interested to hear about what you're seeing in the market from a call responsibility perspective for APPs.
Yeah, so in our organization, it really does vary depending upon service line. We have, as I mentioned, we're kind of affiliated with UT College of Medicine. So we do have a fair number of fellowships and residencies here on the physician side. So as a result of that, you kind of have a body in house, if you will, for multiple specialties. And in our downtown location, we're very resource rich in that sense. In our outside locations that are in different parts of either Chattanooga area or in our other states, obviously we don't have that. And then we have some service lines that don't have a fellowship or a residency on the physician side. So the APPs are utilized a lot more heavily from a call aspect, where they're coming in and actually seeing patients on rounds on the weekends and coming in to see patients at night. We have some providers that just take call by phone and they only ever answer phone calls, and they never have to physically come in and see anybody. So the way they're compensated for that and is going to vary. I meant to mention before, so similarly to Amanda, we have some providers that are not billing. Most of those are our inpatient providers where they are paid a flat salary, and they are not earning RVUs. So like they are basically paid one level of compensation depending upon their shift. So if they're 7 on, 7 off, or, they work 5 8-hour, shifts a week. But those APPs are not paid, for RVUs that they collect, that they are just paid that flat salary. Whereas on the ambulatory side, those APPs are billing, turning in billing, they are, generating RVUs. And so there is that metric-based incentive for them. So our inpatient ones are going to be paid a higher base salary just to help compensate and cover all those added responsibilities around call and what have you.
Yeah. Like you said, all calls not created equal, so it's hard to talk about it. But I think we're seeing the same, and I think the market really talks about how there's three main ways to compensate APPs for call, and one is to have it sort of baked into their salary, and a minimum or maximum call expectation per month. We've been told by some of the firms that we've worked with here that that some certain specialties that is the way that the base salary is calculated. So we should not be worried that we're not compensating folks enough for those specific specialties. We have other specialties who receive an annual stipend for call, similar with minimum and maximum outlined, and then maybe additional pay if they exceed the maximum per month. And then the third, which I think is in the market the most common, and what we have as well, is just being paid by the shift or even the hour for the call. And then you also get into, well, is there then a difference? Do you pay them more if they have to come in? If they're a specialty who, does both, where they can, field calls from home, but sometimes they have to come in and do an admission. Some of our very busy service lines, like neurosurgery, they do not have residents. So the APPs are constantly coming in-house at night over call. So we haven't been able to find a one size fits all. And I think that's ideal, honestly, because the type of work is so different.
Yeah.
And I would say our experience working with clients recently is similar, that this is a hot topic. And a lot of times, again, we see this in the rural communities. Just recently finished projects in North Dakota and Montana about this, because the call burden can be pretty great on APPs in those types of communities. You might have a physician and an APP, that's the team, right? And they might share call 50-50. So definitely a topic for folks should be thinking about.
Yeah.
All right, so last sort of pre-prepared area of questions. So that's sort of what's next. When you're leaders in the area, what do you see on the horizon? Whether it's what's the definition of an APP or the roles they are going to work in, or whether they'll be more independent. Where do you think people need to be paying attention for what's going to happen coming down the road? And I think Leslie, I lost track here. Leslie, Leslie, we're going to give you first on this one.
Okay. Well, so I think that we are going to continue to see, as we've already mentioned, more APPs into the market. Advanced practice providers is really a very broad umbrella, and the roles are going to really vary on what they do. And I think it's going to change to fit the need, honestly, of our kind of emerging healthcare system as it changes with provider shortages in areas where you can't get, people to come and work and take care of people. So I think we're going to see more independence. Like Amanda mentioned earlier, I think we're going to begin to see states shift away from that kind of old fear maybe model around, allowing us to have more autonomy and independent practice. I do agree and have talked with my physician colleagues, like there's such a varying degree of training out there because of the demand. You have all these online programs that have popped up, and you've got, APPs that are dependent upon finding their own clinical sites. It's not really governed by whoever program they're on. So it's not all apples to apples. It's very apples to oranges. And so that can make it really challenging for a state to adopt this independent kind of structure because you're not getting a standardized product from every single, system that they're going back to for training. And so I think that does make it really challenging. In the South, we tend to be definitely a little slower to the table when it comes to advancing from that standpoint. Georgia has actually just passed a collaborative change for their PAs, Tennessee has just changed collaborative nature where if a PA has worked for 6,000 hours in their role, then they can petition and apply to be basically not need a collaborating physician. It's this very new, just happened just a couple of weeks ago. It's going to be I think where we're going to see that practice benefit is in that rural market where you can't get anybody to go and see patients. And what we have had over the last probably 10 years here in Tennessee is almost like a gouging, if you will, where you have these markets where APPs are going to go and fulfill a need, but they've got to have a physician they pay to supervise their practice. There are physicians that were charging inordinate amounts of money, to oversee charts, come into the clinic once a month, what have you, whatever the rules are. And so I think that they're realizing that there's got to be some break point where you say, okay, well, you physician won't go. We've got an APP who will, but we can't break the bank and you overseeing their care. It's just going to kind of, it's going to necessitate those APPs not wanting to go. And so I've been pretty impressed that the PAs got together and were able to pass some legislation. And I'm hoping, honestly, we can see that happen with our MP partners in the state of Tennessee as well. So I just think we're going to see this culture shift as time progresses because of demand. We're going to see some more independence and the roles are going to change.
Yeah, I agree. So Pennsylvania is a very restrictive state from a physician assistant perspective. So it's been only a few years since the co-signature requirements have changed, but they still are in place. 100% co-signature for the first year of practice, as well as new to specialty, which is a barrier. I didn't cite that earlier, but that is certainly a barrier to APP, utilization and scope and honestly satisfaction from a physician standpoint. So we certainly have some work to do there, but it's going to change because it has to. Telehealth obviously is not new, but I think we're going to see more and more of that. As it becomes more expensive to bring patients into offices. It'll be interesting to see what happens with reimbursements for telehealth visits. I think that's going to have to, be re-examined over the next few years. Remote patient monitoring, we do have a couple really successful programs, but I think we're going to see more of that as well. Yeah, I think, everything that Leslie said, as well as sort of the more virtual telehealth stuff is what we're going to see.
All right. Well, good information, folks. Appreciate that. And we've got about 20 minutes or so left for our session today. And so this is when we're going to jump into the breakout room. So this is the opportunity for those of you who are attending today to have a little bit more one-on-one conversation with your peers. So you will automatically be assigned to one of 3 breakout rooms. There will be a moderator or one of the panelists in the room. So Amanda, Leslie, or I will be in one of the rooms. And our role is not to lead the conversation, but just to sort of be there and help guide it. And so we look for you to sort of be self-driven in these breakout rooms in terms of discussing the following question. So what are the greatest APP challenges within your provider enterprise today? What are you struggling with? What are you feeling? And then ideally at the end of the breakout, you would have one person who was, nominated one way or another to just sort of quickly report out. Doesn't have to be a robust, but just quickly in your group, what were some of the biggest challenges you had? And so at this point in time, I'll ask Tia if you can break us out into the groups and maybe bring us together no later than 5:20 to leave about another 10 minutes or so for conversation at the end.
Awesome. You all should see your breakout rooms open. The rest of our members have about 20 more seconds to join us from those breakout rooms. All right, Kevin, the floor is yours.
Right. Let's see here. So I was in one of the breakout rooms. We had some decent conversation in there. We had to push some folks, but we had some active participants. So I greatly appreciate those who share their experiences. So maybe what we'll do is we'll go room by room. I'm not sure what room I was in. We'll call it room 1. I don't know. We'll call it Kevin's room. So if maybe was there anyone who was in our room who felt like they wanted to share something that they shared with the group? All right, if not, then I'll jump in. So one of the topics that we had a couple of good topics. I appreciate it. One was thinking about quality metrics and how APPs can be involved in design, implementation, compensation, improvement, all those types of things. And so we had someone talk about that. We did talk about challenges of growth opportunities for APPs, sometimes related to that, compensation. So how do you ensure that there's consistent compensation across the organization that effectively represents and rewards APPs for their efforts and their skills and their training? Really equity of pay maybe might be the term as it relates to that one. We also had someone talk about the roles of APPs in post-acute settings. And a little bit of the conversation we had was that, post-acute patients are a lot sicker today than they used to be in the past. And that the APP, that's a very important role that they're taking more responsibility for. And that in the future is probably a place that they're going to be taking care of a fair amount of people and some pretty sick people in that place too. So the importance of APPs in that role. So those are some of the topics that we talked about. I don't know if we want to maybe jump to group 2. I don't know if we had a spokesperson for group 2.
I think that was me. I think I was maybe breakout room 2. So, and Mary, I think, is going to report out for us.
Yeah, I am. Thank you for that. Yeah, we had an interesting discussion. Joshua is from Vermont, and so he shared some challenges with retaining, you know, advanced practitioners because, again, you can probably get them there, but then do they want to stay? And it's a, lifestyle and the whole package, right? Um, we were excited really about the forward-looking numbers that you shared, Kevin, at the beginning in those surveys. It's, very great to know people are continuing to go into this. I know myself, I recently moved to New Hampshire and I could not get a primary care doctor. And I'm from Connecticut, and I was just delighted to meet this. Actually, it's PA that's taking care of me for primary care, and she's a New Englander, and excellent, practitioner. So, I think it's more common, and I think it's going to be great to have that as we move forward and have more people. And then we also talked a little bit about AI and the impact. Certainly everyone has some exposure to it now in things like note taking, but is there something bigger, that it'll be more of a health navigator for you and you won't end up until you actually need to be in a hospital, again, conserving these precious resources that we have of our medical practitioners. And then I had asked Leslie if it was common for trajectory in terms of leadership to go into like hospital administration, healthcare administration, because just myself, I'm a pharmacist by background, and I was a hospital administrator for like 20 years, and now I work with BD, a medical device company. So it's just, you're supposed to have 5 careers before you retire. I read that somewhere, so I'm working on that. But we had a really nice discussion, and it was a great group.
That's great. That's great. Thank you for sharing that, Mary.
Thank you.
All right, Amanda, I think you might have had then the last group. Did you have a spokesperson?
We had someone who reluctantly agreed, whose name escapes me at the moment, but hopefully she's she's still willing to give a brief summary. We had great conversation as well, very similar themes.
Yes, this is Michelle. I'm reluctantly going to give our out brief. I might get joined by a minion.
Yes.
So a couple things in terms of talking about just the, broad challenges we faced and very specific ones. Talked about in some cases where partners were reluctant to accept referrals from their APPs. And so in advance, partnering with your partners in terms of understanding how you're going to be using your APPs and getting them on board with it ahead of there being issues with those referrals. Challenges with regards to leveraging APPs to cover full agency requirements through flexible scheduling. Maybe this group is looking for something more of a traditional, 8-hour days. And so when you have a mission set that requires something more flexible, that was problematic for them. Other things that were more related to, nurse practitioners and PAs are great because they can be used and beyond a subspecialty, but we found that there was a consensus in that reporting structures and role definition can be challenging because it can be ambiguous, and then getting shared expectations across the teams. And then I personally brought up, I've had some recent challenges with overseeing physicians being willing and open to our APPs operating at the top of their skill set. So overcoming that cultural barrier, sometimes a little bit old school, and the physicians understanding this is for the good of everyone. So that kind of summarizes our group 3. Thanks, Amanda, for facilitating us.
Yeah, that's great information. Appreciate you guys digging into that real quick. I know it was quick and didn't have a lot of time to get into it, but super helpful. I don't know where we are. We're running out of time here. Amanda, Leslie, last quick thoughts that you want to share with the group? Or
No, I just say thank you. And I think my contact information should be, I think it was on the slide. So yeah, if anyone has additional questions after we get off today, I'm happy to answer.
Same. I appreciate the opportunity to talk to this group and available in the future if you have further questions.
Yeah, great. And I really appreciate again Leslie and Amanda's time today As you can see, they've got a ton of information to share, and just happy that we could have their expertise, and they took the time out of their schedule to do it. And again, appreciate the ACHE of Northern New England for letting us have this conversation, and good to see everyone. And thanks so much for attending.
Have a great night.
On behalf of ACHE, I want to thank our chapter leaders that planned today's session, our moderator, our panelists, and of course, you, our attendees. Please complete the evaluation, which is open for 1 week. The direct link can be found in the chat box. You can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the helpful link section on the right side of the screen. From there, click on the Access My Courses link, and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of virtual interactive education credit posted to their My ACHE account within 2 weeks of this event in the My Education Credit section. That concludes our session, which is copyrighted in 2026 by the American College of Healthcare Executives. All rights reserved. Thank you, everyone, and enjoy the remainder of your week.